Hello, I'm Dr. Nasmani and this is the PGET 2012 session 5 of surgery. Please visit the site youtube.com/acepgmed and also facebook.com/acepgmed. You can see a lot of study materials in this site youtube.com/acepgmed, and also please send this link to your friends who may be interested in visiting internet to get self tutorials. So in this, the question number 20 of the surgery session is discussed. The previous questions up to 19 were discussed in the previous video upload. Please visit. A 65-year-old woman has a life-threatening pulmonary embolism 5 days following removal of a uterine malignancy. She is immediately heparinized and maintained in good therapeutic range for the next 3 days, and then passes gross blood from her vagina and develops tachycardia, hypotension and oliguria. Following resuscitation, an abdominal CT scan reveals a major retroperitoneal hematoma. So you should now do what? Immediately reverse heparin by calculated dose of protamine and place a vena cava filter like Greenfield filter, or reverse heparin with protamine, explore and evacuate the hematoma and ligate the vena cava below the renal vein, or switch to low dose heparin, or stop heparin and observe closely, or stop heparin, give fresh frozen plasma FFP and begin warfarin therapy. So what is your choice? The answer is A, that is, in a heparinized patient with significant life-threatening hemorrhage, immediate reversal of heparin anticoagulation is indicated. Protamine sulfate is a specific antidote to heparin, should be given as 1 mg for each 100 unit heparin if hemorrhage begins shortly after a bolus of heparin. For a patient such as this in whom heparin therapy is ongoing, the dose should be based on half-life of heparin, that is 90 minutes. Since protamine is also an anticoagulant, only half the calculated circulating heparin should be reversed. The protaminization should be followed by placement of a percutaneous vena cava filter called Greenfield filter. In this critically ill patient, exploration of the retroperitoneal space would be surgically challenging and meddlesome. Acute pulmonary embolism is a common and often fatal disease. Mortality can be reduced by prompt diagnosis and therapy. Unfortunately, the clinical presentation of pulmonary embolism is variable and nonspecific, making accurate diagnosis difficult. Pulmonary embolism refers to obstruction of the pulmonary artery or one of its branches by the material like thrombus, tumor, air or fat that originated elsewhere in the body. Pulmonary embolism can be classified as acute or chronic. Patients with acute pulmonary embolism typically develop symptoms and signs immediately after obstruction of pulmonary vessels. In contrast, patients with chronic pulmonary embolism tend to develop slowly progressive dyspnea over a period of years due to pulmonary hypertension. Acute pulmonary embolism can be further classified as massive or submassive. Massive pulmonary embolism causes hypotension, defined as systolic BP less than 90 mmHg, or a drop in systolic blood pressure of equal to or more than 40 mmHg from baseline for a period of more than 15 minutes. It should be suspected any time there is hypotension accompanied by an elevated central venous pressure or neck vein distension, which is not otherwise explained by acute myocardial infarction, tension pneumothorax and pericardial tamponade, or a new arrhythmia. It is a catastrophic entity that frequently results in acute right ventricular failure and death. When death occurs, it is often within 1 to 2 hours of the event, although patients remain at risk for 24 to 72 hours. All acute pulmonary embolism not meeting the definition of massive pulmonary embolism are considered submassive pulmonary embolism. The brain natriuretic peptide, an elevated BNP or N-terminal pro-BNP predicts RV dysfunction and mortality. NP and NT-pro-BNP may predict other adverse outcomes. In an observational study of 73 consecutive patients diagnosed with acute pulmonary embolism, serum BNP level more than 90 picogram per ml drawn within 4 hours of presentation were associated with cardiopulmonary resuscitation, mechanical ventilation, vasopressor therapy, thrombolysis and embolectomy, as well as death. Serum BNP level of less than 15 picogram per ml identified 95% of the patients with a benign clinical course. Reference is given, and in this presentation I acknowledge this article. Serum troponins. Elevated serum troponin levels identify patients with pulmonary embolism who are at increased risk for death. Troponin levels can be combined with NT-proBNP levels to derive more precise prognostic information. In a prospective study of 100 consecutive patients with PE, a troponin T level of more than 0.07 microgram per liter plus an NT-proBNP level equal to or more than 600 nanogram per liter was associated with a higher 40-day mortality than a troponin T level of more than 0.07 microgram per liter plus an NT-proBNP level less than 600 nanogram per liter. I acknowledge the reference given here for this material, which is described in this presentation. Most pulmonary embolism arise from thrombi in the deep venous system of the lower extremities. However, they may also originate in the right heart or pelvic, renal or upper extremity veins. Iliofemoral veins are the source of most clinically recognized PE. 50 to 80% of the iliac, femoral and popliteal vein thrombi, that is proximal vein thrombi, originate below the popliteal vein, that is calf vein thrombi, and propagate proximally. The remainder arise within the proximal veins. Fortunately, most calf vein thrombi resolve spontaneously and only 20 to 30% extend into the proximal veins if untreated. Most lower extremity thrombi develop at sites of decreased flow such as valve cusp or bifurcations. After traveling to the lung, large thrombi may lodge at the bifurcation of the main pulmonary artery or the lobar branches and cause hemodynamic compromise. Smaller thrombi continue traveling distally, are more likely to produce pleuritic chest pain, presumably by initiating an inflammatory response adjacent to the parietal pleura. Only about 10% of the emboli cause pulmonary infarction, usually in patients with pre-existing cardiopulmonary disease. Most pulmonary emboli are multiple, with the lower lobe being involved in the majority of cases. Impaired gas exchange due to PE or due to mechanical obstruction of the vascular bed and alteration in the ventilation perfusion ratio. Secondly, release of inflammatory mediators resulting in surfactant dysfunction. Third, due to atelectasis, and fourth, functional intrapulmonary shunting. Hypotension is due to diminished cardiac output, which results from increased pulmonary vascular resistance, impeding right ventricular outflow, reducing left ventricular preload. Pulmonary vascular resistance is increased from physical obstruction of the vascular bed with thrombus and vasoconstriction. The vasoconstriction is due to the effects of the inflammatory mediators and hypoxia. The symptoms, most common symptoms were dyspnea at rest or with exertion, pleuritic pain, cough, more than 2 pill orthopnea, calf or thigh pain, calf or thigh swelling, wheezing. Signs, most common signs are tachypnea, tachycardia, rales, decreased breath sounds, accentuated pulmonary component of the second heart sound, jugular venous distension. Circulatory collapse was uncommon in such patients. Dyspnea was present. Massive pulmonary embolism may be accompanied by acute right ventricular failure manifested by increased jugular venous pressure, a right-sided S3 and a parasternal lift. Symptoms or signs of lower extremity deep venous thrombosis, edema, arrhythmia, tenderness and palpable cord in the calf or thigh. Arterial blood gas measurements and pulse oximetry have a limited role in diagnosing PE, pulmonary embolism. BNP levels are typically greater in patients with PE compared to patients without PE. However, many patients with PE do not have elevated BNP, that is insensitive, and there is so many alternative causes of elevated BNP, which means it is non-specific. Troponin troponin I and T are elevated in 30 to 50% of the patients who have a moderate to large pulmonary embolism. Presumed mechanism is acute right heart overload. Troponin elevations usually resolve within 40 hours following pulmonary embolism, in contrast to the more prolonged elevation after acute myocardial injury. Electrocardiographic abnormalities historically considered to be suggestive of pulmonary embolism are S1Q3T3 pattern, right ventricular strain, new incomplete right bundle branch block are infrequent finding during acute pulmonary embolism. You can see the S1 Q3 T3, that is prominent S in lead 1, Q and inverted T in lead 3. S1 Q3 T3 prominent S in lead 1, Q and inverted T in lead 3 are well shown here with the arrow marks. Following ECG abnormalities are associated with poor prognosis like atrial arrhythmia, right bundle branch block, inferior Q wave and pericardial T wave inversion and ST segment changes. So hope that the session was useful to you. Even though it was mainly a surgical problem, I concentrated my discussion on the pulmonary embolism because many times pulmonary embolism is not covered in the routine postgraduate training. So that is the reason why I concentrated more on the pulmonary embolism aspect along with the post-operative surgery. Please visit the channel youtube.com/ccpgmed and also please send your queries to this email address ccpgmed@gmail.com or my other email address drnsmanimd@gmail.com drnsmanimd@gmail.com. Thank you.